Hello and welcome. In this explainer, we're going to systematically break down urethritis. We'll cover everything from etiology and diagnosis all the way through to the most current management strategies. So here's our roadmap. We'll start with a solid clinical overview, then get into the nitty-gritty of pathogen identification. From there, we'll talk treatment, touch on some key pediatric points, cover infection control, and wrap up by looking at the serious complications we're trying to prevent. All right, first up, the clinical overview. Let's make sure we're all on the same page by defining the condition itself. So, what exactly is urethritis? Well, at its core, it's just what it sounds like: an inflammation of the urethra. The diagnosis is fundamentally a clinical one, meaning it's based on what the patient tells you and what you can see during an exam. Now, here's where things get really interesting from a diagnostic standpoint. You see this major split in how urethritis presents. In men, it's usually pretty obvious. They come in with dysuria, maybe some discharge, and they're symptomatic. But in women, it's a whole different story. The infection can be completely silent. Up to 90% of chlamydial infections are asymptomatic, or it gets mistaken for a simple UTI. This is a massive challenge, both for diagnosis and for public health.
To put some numbers on it, the annual incidence can be around 1 new case per 1,000 men in some primary care settings. And while we're going to focus heavily on the infectious causes, it's always worth remembering that it's not always a bug. We have to keep non-infectious causes, like mechanical irritation or even pelvic floor issues, on our differential.
Okay, section 2. Let's move into the microbiological detective work, figuring out which bug is causing the problem and, crucially, what we can use to fight it. So, who are the usual suspects? Well, the landscape is really dominated by a few key players. You've got your classic agents like Chlamydia trachomatis and Neisseria gonorrhoeae. Then there's the one we're paying more and more attention to, Mycoplasma genitalium. And then you have this big slice of the pie, non-specific urethritis, or NSU, which is basically the clinical way of saying, we know there's inflammation, but we can't pin it on a specific pathogen. For actually detecting these pathogens with NAAT testing, your sample choice is absolutely critical for getting an accurate result. For men, the best and easiest option is a first void urine sample. For women, a deep vaginal self-swab is actually the gold standard. It's more sensitive than urine, and it gives patients a bit more control and comfort. Let's put this into practice. Picture this. A 28-year-old man walks into your clinic. He's got the classic symptoms. It hurts when he urinates, and he has a purulent discharge. So what is the single most important thing you need to do before you even think about writing a prescription?
The answer, and this is absolutely non-negotiable, is to collect your samples before you give any antibiotics. You need samples for both NAAT, for a quick ID, and for culture. Why? Because culture is the only way we can perform antimicrobial susceptibility testing. With resistance in Neisseria gonorrhoeae becoming a massive global problem, treating empirically without this data is not just risky for your patient, it's irresponsible.
All right, before we dive into the pharmacology, a quick moment for some microbiology humor. Why did the bacterium break up with the fungus? Because there wasn't enough room for them to grow together. Okay, now back to the serious business of treatment. Section 3, treatment. Now that we've hopefully identified our pathogen and maybe even have some susceptibility data, we can get really targeted with our evidence-based management. For an uncomplicated chlamydia infection, the first-line therapy is now a 7-day course of doxycycline. It just works better, especially for rectal infections. For a long time, that single-dose azithromycin was the go-to, but with growing concerns about macrolide resistance, the guidelines have really shifted to favor doxycycline. For uncomplicated gonorrhea, the standard of care is a single 500 milligram IM shot of ceftriaxone, which you'll mix with lidocaine to make it a bit more comfortable. And again, this is exactly why that pretreatment culture is so important, to make sure this powerful monotherapy is actually going to work for the specific strain your patient has. Now, Mycoplasma genitalium. This one is a tricky customer. Treatment here is all about resistance-guided therapy. If you know the strain is macrolide sensitive, azithromycin works well. But if it's resistant, which is increasingly common, you have to pivot immediately to a second-line agent like moxifloxacin. There's no room for guesswork here. And look, the prescription is only half the battle. The advice we give our patients is just as critical.
That means recommending no sexual contact for at least 7 days for both the patient and their partners to prevent reinfection. It's also helpful to advise patients to avoid milking the urethra, as this can just cause more irritation and slow down recovery.
All right, section 4, let's shift gears for a moment and talk about our youngest patients, because management definitely needs some specific adjustments for them.
Dosing, of course, will always follow your pediatric formulary, but there are some specific prophylactic strategies to keep in mind. For newborns under a month old, you're looking at co-amoxiclav. For older infants, it's trimethoprim. And here's a critical point. For any child with suspected cystitis, a urine culture isn't optional, it's mandatory. It's the only way to guide proper therapy. Prophylaxis is also the right call if you culture group B strep.
Okay, section 5. We've treated our patient, but the job isn't done. Now we have to zoom out and think about the public health picture. How do we break the chain of transmission? Partner notification is really the cornerstone here, and the protocols are very specific to the bug. For Chlamydia, Mycoplasma, and Trichomonas, you're focused on current partners. But for gonorrhea, you need a longer look-back period, all partners from 2 weeks before symptoms started. And importantly, if you end up with a diagnosis of non-specific urethritis, partner notification isn't recommended. Finally, section 6, the complications. This is the so what. This is why we go to all this trouble with diagnosis and treatment, because the long-term consequences of leaving these infections unchecked can be absolutely devastating. In men, the infection can literally travel upwards, leading to painful conditions like epididymitis and prostatitis, or causing chronic problems like urethral strictures. And it's not just local. You can get systemic issues like sexually acquired reactive arthritis, or SARA, and with gonorrhea, even disseminated infection leading to septic arthritis. For women, the consequences are arguably even more severe, and that risk is magnified because the initial infection was likely silent. An ascending infection can cause pelvic inflammatory disease, or PID, which can lead to permanent, life-altering damage, including infertility, a higher risk of ectopic pregnancy, and chronic pelvic pain. This really underscores why robust screening programs are so essential. And that brings us to our final lingering question. We have these protocols now, but the microbial world is constantly evolving. As we see more and more resistance to azithromycin, and even to our second-line fluoroquinolones for M. genitalium, what's the next frontier? What's our next move? It's a question that really drives home the perpetual challenge of antimicrobial stewardship and managing infectious diseases.